Hello, everyone, and welcome to this webinar, an AUA newsworthy webinar, and thank you for taking the time to be with us. Today, we're going to be exploring the application of real-world evidence and discussing the results from two head-to-head real-world analyses comparing treatment options for metastatic castrate-sensitive prostate cancer. We welcome your questions at the end of the webinar, and we'll go into some more details a little bit further. As a disclaimer, this is an educational activity that is sponsored by Janssen Biotech, and it's not certified for continuing medical education. We've been paid an honorarium, and the speakers, myself and Dr. Morris, will present data that's in compliance with the FDA requirements applicable to Janssen. It's important to start out by discussing ERLEADA, also known as apalutamide, and its indications. ERLEADA is an androgen receptor inhibitor indicated for treatment of patients of two types. One is metastatic castration-sensitive prostate cancer, and the second is non-metastatic castration-resistant prostate cancer, and those diseases will be abbreviated as mCSPC and nmCRPC throughout the presentation. I'd like to just introduce myself first. My name is Michael Johnson. I am a professor at Washington University and currently serving as Division Chief in Urology. I'm our Society of Urologic Oncology Fellowship Director and have a particular interest in prostate cancer. And joining me today is Dr. Morris, who's going to introduce himself.
Hi. Thank you, Dr. Johnson. I'm Dave Morris in Nashville, Tennessee. I'm president and co-director of the Advanced Therapeutics Center at a large urology group practice, or Urology Associates. And because of that, we run a lot of active clinical trials in prostate cancer and have a very active patient population that fits within the label that we're going to discuss today. So I wanted to just give an update on how the questions will work at the end. There's an ask a question button that you could use, and you can submit questions throughout. We will have a live interaction with those questions at the end of today's webinar. And so we'll begin looking really this kind of our goals for today is to understand the application of this real world data and also a lot of the steps that go into the development of real world studies and kind of the shift in the FDA in their view of what is really done outside of a clinical trial. So real world evidence generation, which is often retrospective, and how we're trying to apply kind of rigorous techniques to analysis of those data sets. And then within urology, we're really going to focus on two of the studies that were done within real-world evidence data sets for apalutamide in metastatic CSPC or metastatic hormone-sensitive prostate cancer. And then really, Mike and I will touch a little bit on how you can use real-world evidence in your own clinics in terms of shared decision-making with patients, because patients are not often all to the letter fitting for enrollment in clinical trials. And so sometimes real-world evidence is better applicable in the clinic setting.
Thanks for that. And I agree with you 100% in what you just said. And I'm looking forward to all the questions that are going to be asked and how we can benefit patients with these studies and the data. To summarize, or to sort of lay the groundwork, it's really important that we cover real world evidence, real world data as a general overview and why it's important. Historically, observational studies have shaped our clinical practice. They've been used for decades to understand natural history of diseases, patient risk factors, as well as patient outcomes. These types of studies have shaped guidelines, and to some extent, we use them for evaluating the relative effectiveness of various treatment paradigms. On our slide here, we see two pivotal studies and examples of how observational studies can be used. These are the Framingham Heart Study and the Nurses' Health Study. The Framingham Heart Study started from 1948 to the present. It had started out with approximately 5,200 patients or participants, and to date, there are 6 cohorts now of about 15,000 participants. This focuses on cardiovascular disease, and this really has transformed some of the clinical guidelines for cardiovascular disease management. And in the Nurses' Health Study, starting in 1976, now has greater than 275,000 participants. And this has created awareness on factors associated with women's health and development of chronic diseases. And it's really shaped public policy and public health standards. Well, what is real world data? What is real world evidence? The FDA defines real world data as data relating to patient health status and the delivery of healthcare routinely collected from a variety of sources, and defines real world evidence as clinical evidence about the usage and potential benefits or risks of a medical product derived from the analysis of real world data. This can come from a number of sources, as you see on this slide. This can include electronic health records, medical and insurance claims data, product disease registries, but also other sources such as research networks, digital health technologies, and surveys. For years, insurance claims have been available to study medication utilization in patient populations and have been relied upon by insurance entities to understand the use of medications in populations. However, insurance claims do not allow for most patient clinical outcomes to be directly studied. With electronic medical records, the data is now being captured in routine clinical practice, and we can study it. This has allowed for improved characterization of clinical populations and studying more clinically relevant outcomes. In fact, the FDA is actively working to create guidance on the use of real-world evidence to better understand treatment effects beyond limited clinical trial populations. To give you kind of an understanding of how this evidence is evolving, we can look at a timeline. And here it is from 2016 to essentially present, and looking at how some real-world evidence has shaped or supplemented randomized control trials. We see that the FDA has consistently developed guidance documents around the use of real-world data and real-world evidence from about 2018 to present. Most recently, a formal office has been will promote the efficient and consistent communication regarding real-world data and real-world evidence to shape future regulatory landscape and within the FDA. And that is the Center for Real-World Evidence Innovation. It's important to understand meaningful real-world evidence studies and that they require the same methodological rigor as other study types. As with randomized controlled trials, the use of real-world data and real-world evidence requires us understanding the strengths, but also the limitations of these data. And when we deal with observational data, it's important to recognize the strengths and limitations of methodologies to minimize bias. To understand these methodologies are applied for causal analysis, which can be defined as the process of assessing true differences between treatments. Randomized control trials are one example of causal analysis. However, causal analysis can be conducted using non-randomized data, such as that from observational studies. There are key elements when we're talking about using real-world evidence. The aim of this is to align observational data with randomized control trial standards and ensure data robustness for causal inference. Key considerations when assessing the rigor in real-world studies fall into three main areas, as depicted by these graphics here. These are the study design, the data sources, and the data analysis. And you can see, for example, study design is really important. We have pre-specified study protocol, clearly defined research questions, a stated hypothesis, importantly with pre-specified outcomes, methods to minimize bias, and sufficient detail to replicate the study. When it comes to data sources, it's really important that it's appropriate to the research question, that we have documented justification of the data source selection, and it's secure, reproducible, and archived. And lastly, in our analysis, it must be pre-planned to determine the correct statistical estimate for evaluating differences and specify critical sensitivity analyses. So focusing more on prostate cancer, the first thing we really need to do is delve into this pivotal study of metastatic castration-sensitive prostate cancer, Titan, which focused on apalutamide or Erleada. And this is the study on which the approval of apalutamide plus androgen deprivation therapy was granted in patients with metastatic castrate-sensitive prostate cancer. This slide here portrays the study design, which I'll articulate now. It was a phase 3 randomized, double-blinded, multi-center, placebo-controlled trial in patients with metastatic castrate-sensitive prostate cancer. These patients, there's about 1,052 of them, and they were randomized 1-to-1 to receive either 240 milligrams of apalutamide once daily plus androgen deprivation therapy, or placebo plus androgen deprivation therapy. All patients received a concomitant GnRH analog or had prior bilateral orchiectomy. The dual endpoints were overall survival and radiographic progression-free survival. The Titan study, importantly, had patients who had diverse clinical characteristics. 63% of these patients had high volume disease. 37, by comparison, had low volume disease. 81% of the patients were de novo metastatic disease at diagnosis. 11% had previously been treated with, but not progressed on docetaxel, cytotoxic chemotherapy. 12% of patients had visceral metastasis. So you can see this covered a very diverse group of patients in the study design. What we're looking at now are the survival data, and apalutamide plus androgen deprivation therapy just demonstrated superior overall survival compared to androgen deprivation therapy alone. On final analysis, apalutamide plus ADT reduced the risk of death by 35% versus placebo plus ADT in patients with metastatic castrate-sensitive prostate cancer. There's also a statistically significant benefit in patients with both high and low volume disease, with a 30% reduction in the risk of death seen in patients with high volume disease, and a 48% reduction in the risk of death in patients with low volume disease. The median follow-up on this was 44 months. When we're looking at survival data, it's also important to look at safety data in the trial as well. Here are the safety data that was established from the Titan trial. This slide shows adverse reactions occurring in greater than or equal to 10% of the apalutamide arm that occurred with a greater than or equal to 2% absolute increase in frequency compared to placebo in the Titan trial. In this study, adverse reactions occurred in 20% of patients in the apalutamide plus ADT arm, and 20% of the patients in the placebo plus ADT arm as well. The safety profile at 4 years remained consistent with that seen in the primary analysis. And so what we look at are some commonly reported adverse reactions, including rash, hot flushes, hypertension, arthralgias, and pruritus or itching. And you can see here all grades, as well as the breakdown of severe toxicity or adverse reactions. Before we go any further into discussing the data, real-world evidence, it's important to go over safety information regarding Erleada. And to that, I'm going to ask Dr. Morris to take over and share some of the safety information.
All right, thank you, Dr. Johnson, for the background on apalutamide and the Titan trial, and also real-world evidence and the shift really in the FDA from such a reliance on clinical trial randomized data to more applicable data sets that may be utilizing real-world data. But before we jump into the data from the real-world analysis, I want to update really just the kind of balanced approach for what the safety trade-off is for the overall survival improvement. And so the ISI for apalutamide Erleada is pulled from the two trials, the Titan for the metastatic hormone sensitive, and also from the Spartan, the non-metastatic CRPC trial. And you can see them presented here. And so often these percentages combine the data sets from both of those trials. You can see Cardiovascular and ischemic cardiovascular events were a slightly higher rate in those treated with androgen receptor along with ADT, more than just ADT monotherapy alone. So usually we explain to patients that does increase their risk of things like stroke and non-fatal MI, a congestive heart failure, or MI that could be fatal, all by small percentage points. But when you talk about thousands of patients, a 1% difference can be meaningful. And so really that's a call to us as managers of these men with prostate cancer to make sure that they have maximized cardiovascular care and that they're not depending on their urologist to be their cardiologist. So we really try to make sure they're connected with primary care or cardiology for that improvement in terms of ischemic heart risk. And then if they have an event, we usually will discontinue and talk to their cardiologist about alternatives, if there are any, for advanced prostate cancer if needed. Falls and fractures, we're seeing a slightly higher risk of men treated with combination therapy versus ADT alone. It's about double the rate. Now, patients taking Erleada also had longer exposure to Erleada than often the placebo arm due to progression in the comparator arms. So these are not rate controlled for exposure risk, but there is a slightly higher risk of falls and fractures. Seizures were noted in patients treated with Erleada in both the trials, although the rates were low. You can see 0.4% in one trial and 0.1% treated in the placebo arm had a seizure. So seizure rate is increased by taking Erleada. If someone has an active seizure event, they should discontinue therapy. And patients were screened as part of the clinical trial to make sure that they did not have those risk factors that could increase their risk of seizure. Along the lines of rash, which Dr. Johnson pointed out earlier, there were episodes of very aggressive rash, including scars, severe cutaneous adverse reactions, including things like Stevens-Johnson. And so really we're monitoring for rash development and trying to be upfront on top of it with patients before they have a progression that would require more intensive therapy and consultation with a dermatologist. But most low-grade rash, if you're paying attention, you can do drug holidays, stop the drug, or manage with topical or steroid therapy. In most of our clinical experience, it's really about kind of proactive management of rash development. Interstitial lung disease and pneumonitis were seen in patients treated with Erleada, although the rates were very low. You can see less than 1% in post-marketing cases. And so if patients have new worsening symptoms of pulmonary distress, that you should stop Erleada and have consultation with a pulmonologist. And with any AR-directed therapy, there can be fetal toxicity. So this has not been studied in women that are pregnant. And if they are of pregnancy potential or the man is with someone who could become pregnant, they should use effective contraception during treatment and for 3 months after the last dose of Erleada. There were some most common events. These are what would present in a television commercial that happened 2% more than placebo and more than 10% of the time. And that's the ones that were presented in the graph earlier: rash, fatigue, arthralgias, fall, weight decrease, hypertension, hot flashes, diarrheas, and fractures. And then also lab abnormalities, as noted during the trial. You can see several listed below, including changes in lipid profile, but there's nothing in the label for monitoring that is needed for Erleada for safety. Rash specifically was a higher rate versus placebo, including both all grades and even up to the grade 3 and above. The median onset of rash was right around 3 months. 78% of patients would have resolution of the rash if they were taken off the medication, typically managed with oral antihistamines and topical steroid creams. There were 19% of patients who had to go on to systemic corticosteroids. And then rash could be avoided by restarting the medication. There were about 50% of patients who could have a recurrence of rash versus around 50% who did not have a new rash by restarting the medication at a lower dose typically. Hypothyroidism was noted in the studies. We're unsure if that is related to lab changes in TSH being elevated. But if someone is on thyroid replacement therapy, that you need to continue monitoring for that, and they may need a dose adjustment of their thyroid replacement therapy. Drug-drug interactions are becoming much more common in urology. We recommend obviously utilizing your specialty pharmacy if needed for many of these drugs, but anything through the liver pathway, you can see a whole list of CYP enzymes, including CYP3A4, 2C19, and 2C9. And so with those, concomitant use with Erleada can cause abnormalities in the other drug Erleada impacting it, but it can also occur the other direction where drugs are impacting Erleada's exposure within the body. Of specific call out here, P-glycoprotein, breast cancer resistance protein, and P1B1 substrates. And many of those are statins. So you may have some interaction with statin medications if patients had those listed. But usually we're recommending at that point, you're typically dealing with a pharmacist who can help guide if you need some sort of dose adjustment for either medication. So now, having walked through the safety information, we're going to shift gears now and talk a little bit about what we're here today to discuss, which is the real world evidence and what are the data sets that really support any sort of hypothesis generation in the real world that's not just reliant on the clinical trials. And so we're going to present two specifically today and kind of walk through how they were developed, what some of the rigor around their analysis is, to really get to the idea of, does this answer the question that we're trying to answer? And so this is the first that we'll go over today, which is a head-to-head comparison in a U.S. clinical urology practice data set between apalutamide and enzalutamide in patients with metastatic castration-sensitive prostate cancer. So just high level to talk about this background is at the time of the data pull to get to these cohorts, they both were approved for use in that patient population of metastatic hormone-sensitive or castration-sensitive prostate cancer. And so really the hypothesis was seeing if there was a survival difference at 24 months. And so the kind of first part of the study was, that's the hypothesis. We're going to look at survival at 24 months in patients treated with apalutamide versus enzalutamide. And then it was all about creating and crafting a data set that can be valid for that analysis. And so they used two data sources that were brought together and meshed to basically make sure that they have validity. And so one of them was the clinical data pulled from PPS, which is Precision Point Specialty Analytics software. It's in use across many large urology group practices across the US. That included about 80 to 90 large clinic groups that were managing patients with advanced prostate cancer. And so that's where the clinical data was pulled, and prescriptions were pulled as identified as patients who would be starting apalutamide or enzalutamide. And then they were merged with the Komodo research database to make sure that they were getting appropriate fills, tracking for survival. And so really those two data sets were what were kind of linked together. And then on the right-hand side of this slide, you can see that there's kind of this walkthrough of basically looking at least one paid claim for any ARPI from the index date, which was when both drugs were approved in 2019, was over 20,000 patients from PPS's linked data set to Komodo. And so then they're pulling down, pulling out patients to get down to the appropriate data set of metastatic castration-sensitive, which led to almost 4,000 men with apalutamide as the first claim, and enzalutamide was around 7,000 men with the first claim. And then they further culled it to make sure that they met criteria for castration-sensitive prostate cancer. They couldn't have been on ADT for extended years, where it would suggest that maybe it was being utilized for a castration-resistant disease. They couldn't have any other androgen receptor inhibitor pathway medications used. They couldn't have been on any estrogens or had immunotherapies or PARP inhibitors or other therapies that might kind of skew the results one way or the other. And so the final data set for this was 1,800 men with apalutamide and 1,900 men with enzalutamide, and that was the comparison group. And then they were tracked for basically survival claims. So you can see the study period here was end of 2018 through 2023. And as Dr. Johnson mentioned earlier, that was kind of during this process and the timeline when the FDA was kind of recognizing that real world data had value. Because the patients that are going into this are direct from clinic. They're not culled down with all the inclusion-exclusion criteria that a clinical trial would use. And so now we'll just jump to some of the baseline characteristics between that 1 to 2,000 group men, enza and apalutamide. You can see here age and everything is fairly matched between the two, well balanced. Standardized differences were less than 10% between these two groups. So they used inverse probability treatment weighting to account for the differences from the baseline to try to basically ensure that statistically this was a valid comparison between these two groups, because this was not randomized. I will point out a couple important things on this slide. The African-American population was over 20% from this data set. which is much more in line with the real world of US population-based men than what we often see in the clinical trials that are based off a global population. So 22% is much higher than we see in any of the registrational studies that include populations from outside the US. Metastasis type, you can see de novo was around 50 to 60% in both the groups. As Dr. Johnson mentioned earlier, de novo was more like 80% in the Titan trial. So this did have a bit more of recurrent disease patients than de novo patients. Prior chemotherapy was lower in this subset. This is coming out of urology clinics. It's probably not that surprising that it was only 2 to 3% of men as opposed to the 11% seen in the Titan trial. And then most of the men were going to be at higher Gleason score. We typically would expect this to be 7, 8, 9s, and 10s. And that's kind of what you see presented in the table for the Gleason score from the earliest documentation within the medical record. Most recent PSA level is basically looking at the time at which what the PSA was when they were starting therapy. And we're seeing about a third of the men were in the over 10 group. So that's certainly a higher risk. Some had most recent PSA levels because they'd started ADT and had not started combination therapy, but their ADT brought their PSA down. And so some of them were undetectable because they initially started ADT, but had not yet been on the AR agent at that time. So here are the Kaplan-Meier curve of kind of the survival curves for these men in this cohort. So for this cohort specifically of this community-based urology practices, there was a 23% reduction in the risk of death if a patient was taking apalutamide versus taking enzalutamide. And so you can see the percentages off to the right side. Apalutamide survival at 24 months was 87%. Enzalutamide was 84%. Now, just below that, they show the OS taken from the registrational studies. So the Titan study that was presented earlier, if you'd looked at that Kaplan-Meier curve, the Titan survival at 24 months was around 82%. The overall survival for the ARCHES or enzalutamide registrational study for this patient population was 86%. So there's internal validity that these numbers seem right. And I'm very happy as somebody in the community, but also as a trialist, that we're seeing similar sort of survival levels in a real world data set versus a clinical trial. Often what we see is clinical trial patients do the best of anyone because they're the most called down to be the best patient risk. And so it's great to see that in the real world, we actually get survival that's very similar to what was seen in the registrational studies. Now, I will point out the big caveat here. This is not a superiority claim. There's no prospective head-to-head trials comparing either of these drugs, comparing the safety of these drugs. So this is just a causal head-to-head kind of analysis. We can't say why this is a difference. It may have nothing to do with superiority of the drug. It may have to do with tolerability. There's a lot of hypothesis generation on what this means. And as any data set for real world, there are limitations. This has to do with coding. This has to do with claims. PPS runs on the back end of most of our EMRs, and everybody has a different EMR in large urology groups. So they're trying to pull data and put it into appropriate categories, but there can be some miscoding. Now, there's a lot of steps done to cull down. You remember the original giant data set. Each of those steps is whittling down patients by putting in criteria to kind of exclude those that may not fit in the correct way. And so the other claims that could be wrong, and this goes for both of the data sets we're going to talk about, is these are survival estimates based off claims of death. And so Komodo Research Database does a pretty good job of capturing death events, but it's not 100%, just like any of our ability to track patients for survival and try to assign a time of death. There are going to be some that are off because of timing. And so it's possible that not 100% of deaths were accurate in terms of timing. Regression analyses were done. They can only adjust for the covariates that we know and are able to measure. So there's often unknown covariates in non-randomized data, and they're unable to kind of adjust for those. Now, they tried with weighting to have it be more comparative, but these are not the same groups of patients randomized to one drug or the other. And so the statistics for this was a simple data cut at 24 months, which is very different than the clinical trials, which weight their statistical plan versus a number of events. So they're basically tracking until they have a certain percentage of death events to then do their analysis. This was just saying at 24 months, how many patients are alive. And so you'd need longer follow-up to see the full kind of effect, because some of that effect may get muted down the road. But just at 24 months, this was the data looking at the difference between the two drugs. And so now I'm going to just, as a mirroring study, present here apalutamide versus abiraterone, same sort of setup. So both of these were utilized in metastatic castration-sensitive prostate cancer. The same sort of analysis, the same data set using PPS from the community urology clinics, as well as Komodo Research Claims Database to track some of the death events and the administrative fills for the drug. And you can see here over 20,000 men that fit metastatic castration-sensitive from that data set time frame from the index date. Those are weeded down to 4,000 and 6,000, and then further weeded out with other sort of exclusion criteria like other medication utilization. So the cohorts for this analysis, apalutamide was 1,800 men, and the abiraterone was just over 2,000 men. The study period there you can see is a little different because abiraterone approval time and apalutamide approval time was different than the apalutamide overlap. And so this is 2018 to 2023. And another kind of retrospective longitudinal following to look at survival at 24 months, just as was done on the previous analysis. So here, very similar to the previous data set, looking at difference, generally very matched between them for something that's not randomized. This is just a snapshot of community urology across the US who's presenting with metastatic hormone-sensitive or castration-sensitive prostate cancer. They use the same inverse probability of treatment weighting to try to account for some of these differences. This data set looks very similar to the one before. You can see slightly lower rates of African-American men. This was just under 20% in both of the groups. When you look at de novo prostate cancer, this was slightly higher. This was at 60% versus the 80% we saw in the Titan study presented earlier. Use of ADT going into therapy was about 3/4 of men. Obviously, everyone is going to be on therapy once the index date starts and they get their first fill. Most recent PSA level, very similar to what was seen in the previous analysis with apalutamide and enzalutamide, and also a very low rate of chemotherapy, just around 2 to 4% in both of these groups. Looking at Kaplan-Meier or progression curves, you can see here there was a risk reduction, 26% risk reduction of death at 24 months for patients taking apalutamide versus those initiated on abiraterone. And once again, the OS numbers at 24 months off to the right-hand side, you see out of this cohort for apalutamide, it was 88% survival at 2 years. Abiraterone was 86%. And then the OS at 24 months, as we mentioned earlier from the Titan study, was 82% at 2 years. And the Latitude, which is the closest to this data set group, was abiraterone, and that's 87% at 2 years. Once again, this is not head-to-head. It's not that, they're not enrolling in this treatment. This is treatment determination by the clinical physician in practice, and this is kind of a retrospective view back of how that patient does longitudinally over time. So really can't make any claim as to why there's a difference at 2 years, but this was the difference and risk reduction that was noted. And that confidence interval, it was significant, statistically significant. So the hazard ratio of 0.74, which is the inverse of the 26%, is a confidence interval from 0.6 up to 0.93. So a p-value of 0.01. So these were significant outcomes of difference in terms of risk reduction. So limitations here are very similar to the previous study. There's one additional limitation, which is that abiraterone acetate was only indicated for high-risk metastatic CSPC, which was one of the definitions from the Latitude study for enrollment, looking at risk categories that had to do with Gleason and PSA number. So that may lead to some differences that are not captured on the baseline characteristics that could be controlled with the inverse probability of treatment weighting. But the other same limitations that we mentioned earlier is that we may not capture every event. These are obviously not totally balanced studies because they're not randomized and they're not enrolling concurrently, although it's the same time frame of data analysis and patients from the same era of treatment were going into this data analysis. So, this is a question for Mike and I, just to kind of say, like, how are we utilizing this? And kind of, I'll pose that question to you, Mike, just to start. Like, have you discussed anything like real world evidence data with patients, or is it, I lean on the Titan study as a way to kind of explain what to expect? Or do you like using this in your clinic?
Yeah, thanks for that question. I do like using these data, and I find them helpful. I think uh, patients, when they are trying to understand their treatment and trying to understand what their outcome may be, it's good to focus not only on the randomized control trials and the things that led to FDA approval, but also on what they might expect across a broad population. And the patient who's coming to see you isn't necessarily a study patient. They're your neighbor or your, someone down the street, and they want to just know, in the general population, how are they going to fare? Does that study apply to them? What's on the horizon? So I think these real world data studies have a lot of utility, not only to support us in saying what we're doing is the right thing, but also to give some uh, comfort, education to patients. I might pose that question back to you as a guy who is leading a large urology group practice. How do large urology group practices use these data?
So I totally agree. I think it's almost more applicable to patients to talk about real world data than it is to talk about trials. I'm a trialist. We had patients in the Titan study. Um, I have PPS running in my software. So we have patients that were in both of these analyses. Um, so I guess when I can say things like in my clinical experience, that's my clinical experience, patients actually being pulled and are part of that data analysis. So I would say that of the average person that I see in clinic where we have this, you're metastatic hormone sensitive and we need to make a drug choice, only about half of those patients are probably eligible to be in a clinical trial. They have other comorbidities, they have travel restrictions, they have concerns about their other health issues. They're not the best patient to be in a study. And so I don't know how to say they're going to do. And actually, before this data was presented, I would have say, typically the kind of trial outcome is the best case opportunity. So it's great to now be able to say, like, no, in a real world giant population, thousands of men, just like you, because it's everybody, the outcomes were just as good, and in some cases look potentially even better than what we saw in the clinical trial. So I think it helps in that general global sense. But then you talk about African American men, where it's like, well, I mean, were there any patients like me in this study? And the answer is, like many of the global studies, it's a small percentage. So to say, hey, it's 1 out of 5 guys in this analysis, almost 1 out of 4 guys in this analysis was African American, that makes me feel better about you're going to have similar outcomes to what was seen in the trials, because we usually have to, hope that the trial data applies to the patients we're seeing in front of us. And so this is the way to say, nope, the data from the patients in front of us looks like the trial. And I think most of the patients take that very well.
Yeah, I agree. I don't think you can have one without the other. And the, the original trial is really good in showing that this does something, and the real world evidence says that this is how it's really going to potentially help the person who's seeing you in clinic.
Yeah. And I like the rubber meets the road sort of, idea. Like that got the drug approved. Now this is the proof in does it really work when we use it the way that we're hoping to use it? And this is an application that shows that it mirrored it very well. So
Yeah.
I'll run through a couple of summary statements, and then I think we'll move on to the question and answer section. So as Dr. Johnson pointed out earlier, there's a history in the U.S. medical field of using real world evidence to kind of guide this crafting of our guidelines to support what we think of as good public health recommendations. But there's been a shift in the FDA to saying, all right, if you do this with a lot of rigor, and if you have a priori sort of outcomes that you're looking at, and you've got a statistical plan, and you're modeling it almost like they would a clinical trial, you can use good data sets. Now that we have the benefits of EMR, this is the trade-off is, thankfully we put our data somewhere. Now we're actually able to use it. And so for this, we were presenting really the Titan study being the trial outcome. And now here, these 2 new published studies looking at head-to-head comparisons in a real-world data set in large community urology practices, apalutamide versus enzalutamide, showing a 23% reduction in risk of death at 2 years, and apalutamide versus abiraterone, showing a 26% reduction in risk of death at 2 years. And so I think that can really help craft the patient discussion about real-world patients versus clinical trial patients. And so we thank you guys very much for your attention today, and we'll kind of move on to the question and answer section. And if you've submitted, you can use the ask a question button and type those in. We'll address those now, or we will be able to get back to you in writing from someone from the medical science team at a later date.